So I see a lot of people doing parallel wiring. You already have a wire in the subintimal space, you leave it, and then we get another wire. But parallel wiring is not meant for re-entry, and that means that you redirect the second wire either proximal to the CTO segment or within the body of the CTO segment. Now, this is parallel wiring. And you make use of the presence of the first wire as a marker, but it will also straighten any excessive tortuosities within the vessel. So that's one thing about parallel wiring, which is quite useful in some scenarios. With the retrograde approach, when do we really want to use it? It's when we have an ambiguous proximal cap, sometimes when you don't have an antigrade option, like ostial RCAs, or when the distal vessel is diseased, and obviously you have appropriate collaterals and the necessary expertise. And this is how a CTO operator would evolve over time, mastering antigrade wire escalation, then going to reproducible and safe ADR techniques, then retrograde CTO via safe collaterals, that is septals and SVGs, then finally retrograde via epicardial collaterals. And I skipped the algorithms, the vast majority of you are familiar with them, but what we've seen over the time is that the latest consensus document, this is 102 operators from all around the world, we've come to agree that the hybrid algorithm is mostly similar. So there are no major differences between what is being done in Europe, Asia, or the US. There are the peculiarities, obviously, but more or less they are very similar. So when do we move retrograde? Simple as the more complex the anatomy is, that is higher JCTO score or Castle score or Progress CTO score, you will be utilizing more retrograde, you'll be utilizing more ADR because antigrade wire escalation does not really work in such complexity. And therefore, regardless if you're thinking antigrade or retrograde, the presence of more complexity necessitates more dissection re-entry techniques, be it antigrade or retrograde, which is reverse cut. And why does retrograde really work? Because A, the distal cap is usually tapered, unlike the proximal cap, which makes it less ambiguous. And because it's subjected to collateral pressure with less pulsatility rather than the systemic pressure with high pulse pressures, it is usually much softer than the proximal cap. And similar to what we've seen on the antigrade approach, these are the key components of the retrograde approach. And they are similar to a great extent with three important differences. One, you're going to select collaterals. You want to cross those collaterals. You want to externalize a wire, and importantly, you want to remove the retrograde gear safely. So with collaterals, this is what an ideal collateral would look like. It doesn't exist really in real life, but the more features of what you see on the right-hand side you have, the easier and safer a collateral it becomes. So an obtuse angle of exit and entry from the donor vessel and into the recipient vessel, minimal side branches, less tortuosity, large size, these are all favorable features. We don't really care about Rentrop classification, but Gerald Werner introduced his collateral grading years ago, and the bigger they are, they would take a higher value. So what collaterals exactly can we use? They can be septals, they can be epicardials, or an SVG. And each come with the advantages and disadvantages. With septals, A, they're safer. Perforation is very unlikely to cause tamponade, unlike epicardial vessels. They are hardly the single or dominant collateral, so while they can do or cause some chest pain, they don't cause hemodynamic compromise. And in difficult situations, the microcatheter is not crossing, they can be dilated. Epicardials, they are occasionally the dominant collateral. They're occasionally very tortuous, and if you end up with a concertina pattern, you can run into hemodynamic problems, and the perforation is definitely going to be much riskier, and they do require more expertise. SVGs, they're beautiful. Even if they're totally occluded, we can use them. They're safe, they're big. If you perforate them, which is very, very, very rare, you run into a hemothorax rather than a tamponade. But they can be dilated as well. The only drawback is anastomosis can be very difficult because of the angulation. So this is an example of how we look at septal collaterals, and you can see that there are plenty. You would want to avoid the very proximal ones and the very distal ones. The very proximal ones tend to connect to the PLA rather than the PDA. The very distal ones tend to have an epicardial course. Epicardial collaterals, they can be beautiful, such as this epicardial collateral around the apex, but they can also be very challenging with a lot. That's not working. Very challenging with a lot of high-frequency undulations and tortuosity. So you want to get to the collateral with a workhorse wire, and this is also, sorry. You want to get to that with a workhorse wire because you don't want to ruin the tip of your collateral crossing wire. And there are different maneuvers for difficult collaterals to engage or difficult septals to engage. And then once you get into that collateral, you want to cross it, and there are different techniques we use for septals versus epicardias versus SVGs. With septals, we use what we call surfing. Surfing is an aimless. We just twist, rotate the wire. These are usually soft wires, a sine or a sine black or a SO3 in difficult anatomies, and you would want that wire to follow one septals. If you find buckling or phase resistance, we would throw it, we rotate it, we introduce it in a different direction. So it's not really a guided procedure as such. The lower the heart rate, that will help because you make progress with the microcatheter and wire during diastole, and it doesn't really require a lot of expertise. Epicardias, on the other hand, they're always contrast guided. We don't do them blindly, and we never dilate them. SVGs, even if they're totally occluded, you would want to use an intermediate stiffness polymer jacketed wire, so the Pilot or Gladius are excellent, and with acute angles, we'll just see that. We'll see how we handle acute angles. Now, this is an example of septal surfing, and you can see that we have our microcatheter proximally in that septal, so as not to commit ourselves to one of the branches. And this is a sine wire. We face some resistance. We don't push. We pull back, and it doesn't really require any force. If you are following the right track, it will just follow through. And you can see that, again, without tip injections, it's following through. With epicardias, this is different. You really want to do the selective injection to understand what's going on. Sometimes you can use a septal-to-septal collateral, such as this scenario where you don't have the only source of collateral supply to the LED is via a septal-to-septal connection. And again, you can see that once you have the proper pathway, this is going to distal, withdrawn, and you have a connection. With epicardials, you want the selective injection, and this is again not working, but you really want to understand the anatomy in more than one view because you don't want that wire to deviate in the wrong direction. This is an example of a very small and tortuous epicardial collateral, but I'm putting this to show you that when you understand the anatomy with the current technology and expertise, this can be crossed very safely. And for the sake of time, this is a SO3 wire moving very beautifully in a very tortuous collateral that I would say years ago we would not even attempt. And then once you made the connection, that becomes a relatively straightforward reverse cut. That's an example of an SVG, and I just want to draw your attention. You can see a degenerated SVG, and we decided to treat the native coronaries. We can see the difficulty with all the tenting happening at the site of anastomosis, how to get back into the body of the CTO, and this is where a dual lumen microcatheter can become very handy because it gives you the necessary support as well as the coaxiality for a CP12 on this occasion to progress into the CTO body. Now, there are also different ways you can use collateral. So you can use the SVG to a donor vessel, which gives collateral to a CTO vessel. So this is another use of SVGs, a totally occluded right coronary artery with a patent SVG that gives, via the distal PL, an epicardial collateral to an obtuse marginal branch. And this is how you made use of the collateral to go, the SVG to go into the right coronary artery and then into the obtuse marginal. This is not common. It's more present in Eastern Asia and for redo cabbages or when, for whatever reason, a surgeon would run out of grafts. But this is an example of a coronary to coronary SVG. It obviously requires that the donor vessel does not have any severe proximal disease, but this is an SVG between an obtuse marginal and an LED. And we actually utilize that to go retrogradely into the LED. So there are different uses of the retrograde approach. These are some variations. Now, for the sake of time, I really want to take you to the important part. So you can't obviously do CTO PCI without microcatheters. I'm sure you all know why. We have a stable, steady base of operations. It gives you the support. It gives you the chance to change wires, but it also allows for wire exchange at different stages. And once you get into the CTO segment, we've reached the CTO segment now with our retrograde wire, and you have options either direct crossing true to true, retrograde dissection reentry, which is essentially reverse cut, or a kissing wire technique, which is not really a retrograde procedure. You have a retrograde wire as a marker, but you manipulate the antigrade wire. With direct crossing, we've just discussed that with antigrade, so there's no difference there. With kissing wires, it's mostly an antigrade procedure. You're just throwing your retrograde wire as a marker, and you're manipulating your antigrade wire. But with dissection reentry, it is reverse cut that we will use in the vast majority of instances, and it is simply trying, we don't really care about where the antigrade wire is, whether it's intra-plug or extra-plug. We don't care where the retrograde wire is, where it's in the intra-plug or extra-plug. They're both in the CTO body. They're both within the vessel architecture, and then a balloon over the antigrade wire will help create a common channel that you can push the retrograde wire through. So we'll skip the visual examples just to make sure we remain in time. But this is how we would do a reverse cut in different scenarios and different anatomies.
Ahmed, go to conclusion, please, because
we are getting there, Helen.
Yeah, maybe we have a lot of
So
discussion.
the last slide is when to remove the retrograde gear. So this is important because we see you've done a long procedure, it's successful, and you're left with one thing that can actually lead to problems. So once you've finished the procedure and you want to remove your wire, if you remove your wire straight away, you will cut through the vessel that you're working at. So you want to re-advance your microcatheter until it reaches the retrograde microcatheter, until it reaches the antigrade guide catheter. Then you disengage both guide catheters because they're interdependent. If you start pulling on the microcatheter, your retrograde guide will simply dissect. If you're working in the right coronary artery, you can dissect the left main. So you want to disengage both guide catheters, remove your retrograde microcatheter gently, leave some of the externalized wire hanging within the collateral because you want to do a check injection from the antigrade side. Make sure that you have not perforated the collateral you're using. And once you're happy, you can remove the entire system together. Thank you very much. Questions?